Welcome, GynoCurious listeners. I am your host, Dr. Amy Novatt. From both sides of the speculum, we are here to investigate what it means to be a healer and to be healed. Please let us know what you're thinking about GynoCurious. Send us any inquiries to gynocurious@gmail.com or to radiofreerhinecliff.org. Please consider giving us 5 stars, liking us, and sharing the show with your friends, and just let us know what you're thinking. So, I've had the pleasure of speaking with Keri Gill Smith on GynoCurious, so I've asked Keri to return to expand on her amazing knowledge and to teach us a bit more about lymphedema and introduce lipedema to me and to the audience. Both of these conditions I've seen in my gynecological patients, but so little is known out in the general public. Keri and I are also going to kind of pivot from there today to speak about exercise from a physical therapist's point of view. So a reminder, Keri is a physical therapist and the supervisor of physical medicine at Northern Duchess Hospital in Rhinebeck, New York, which is a part of the Novatt system, and I think soon to be or already a part of Northwell. Is that correct, Keri?
Soon to be, perhaps.
Yeah. Okay. So good morning. Thank you so much for being here again today.
Thanks for having me.
Yeah.
Glad to be back.
So let's just start with just a brief review of what lymphedema is for those who might not have tapped into the earlier show.
Sure. So lymphedema is a condition that occurs when there's some sort of damage or malformation to the lymphatic system. The lymphatic system is a circulatory system in our body that really moves fluid around. It's also part of our immune system. People are kind of familiar with lymph nodes usually, and that really mediates a lot of immunity for our whole system. So when lymphedema occurs, what we have is a failure to move lymph from a certain body part adequately, and as a result, we see swelling in that body part. And unfortunately, that swelling is, once it's sort of there, is really a chronic condition that people are going to live with for the rest of their life. And people like me who are lymphedema therapists help them manage that condition and hopefully keep it under control and have as minimal life impact as possible.
Great. Thank you. Thank you. So one of the things, we had such a nice show about all this, so I just wanted to make sure there were a couple of things that we got to. And the one that I don't think we talked about, which is so prevalent, is the woman who comes into the office or the ambulatory surgery setting who says, you can't take my blood pressure on the arm on the same side as where I had breast surgery, mostly for breast cancer. And I'm wondering, I've heard all kinds of, it's not true, it is true. And then I think about the compression stockings and arm bands that we talk about to treat lymphedema. So tell me, what is the science saying about this phenomenon of blood pressure cuffs on that arm?
Yeah, so all of things around lymphedema really came from a don't do this kind of perspective, right? We don't understand this condition, so what we're going to try to do is just not cause harm. And so the idea is if we're very restrictive and give people a lot of restrictions, they're not going to hurt themselves, right? And that seems really safe. We might be limiting their life and causing, a lot of other issues, but
Right.
but that's really where it came from, a good place, I would say, right? And there was a lack of knowledge. So what we really see now is that there is good research, and most of the surgical professional associations, the breast surgeon societies, various ones of these are all coalescing around what randomized controlled trials and things like that are really saying, is that there really isn't significant risk with things like blood pressure and blood draws on the at-risk extremity. So when someone has a lymph node dissection or they've had surgery, something that's radiation, things that are impacting their lymphatic flow in that area. So when we're talking about a breast cancer patient, it would be the arm on the side of the breast cancer that's impacted. Historically, they were told to preserve that arm and not let anyone touch it, right? And again, from a good place of we don't want to create lymphedema by potentially creating a tourniquet or some sort of inflammatory response with a blood draw. However, what that also does is it unnecessarily delays people's procedures, right? I need contrast to get this procedure done so that you can manage my cancer that's ongoing, and I'm not getting it done because I'm so worried they can't get it line on the other side. I'm not letting them use this limb. And so we've created this fear in our patients, and slowly but surely we're seeing, again, the adoption of these newer sort of least restrictive rules regarding preserving that limb. And that really, again, it really is safe. There's a 0.001. It was also, you might get an infection. Well, how many infections in your medical career have you seen from someone having a blood draw done?
Rare.
Infinitesimally
Right.
small,
Exactly.
right? And so,
Exactly.
so again, it's really at this point in time, people for the most part can feel very comfortable allowing that limb to be used, right?
Yeah.
If they have lymphedema in that limb, that may be a different story. But the at-risk population, which is probably the largest group that we're talking about, that is terrified that this is going to cause them to get a chronic condition, they really, can feel safe in allowing that limb to be used.
Yeah. So we may have touched on this last time we spoke, but I wanted, it's taken so long for us to know about lymphedema. And, does it take Kathy Bates, a celebrity, to bring out an issue for science to follow suit? I mean, why are we so far behind? And it's a rhetorical question because I've said it many times on GynoCurious. So much of science, particularly research and development, is never done on women. So this is, I guess, question, is this a problem that more women have than men?
Absolutely.
Okay.
Right.
And is this why there's so little science on it?
Likely, right? So I think combinations of things. I think there's also, when you talk about, so lymphedema is either occurring as a result of some sort of malformation. So, they have what we call the primary lymphedema, where they've been born with it because there's some deficiency in the way the lymphatic system was formed that's not allowing it to move fluid. Those are primarily female, right, when we start to see those. And then what we see is so certainly cancer is the other major cause of lymphedema in the United States. And that, the breast cancer population, the numbers being so high, that really drives the number of patients that we're seeing to be really predominantly female. And I think you look at the history of breast cancer management in the country, and, we are just sort of following, 20, 30 years behind. I think the changes in behavior of, 1980s, 1990s, don't talk about this, don't allow anyone to see it.
Right.
Right. And so what we're seeing now is really great change, I have to say. This is one of, the best things, right? Kathy Bates has been an amazing advocate, an incredibly strong and, strong woman who's going to the Capitol and lobbying consistently, getting NIH funding specifically for lymphatic diseases. So I think the future is really bright. We are learning more and more about the system. It also has so much potential. We don't understand the anatomy and actually understand the function of the lymph system. So we're not going to be able to understand how to treat the hallmark disease of that system without understanding the first part.
Right.
And so we're finally getting to the point where I think we're going to understand that better. And it is because people are driving, attention to it. And it's also patients who have taken up advocacy. Again, certainly the breast cancer population, is an advocacy driven kind of group who have moved the needle. And I think what we're seeing now is we're actually finally seeing those research dollars allocated towards this disease.
Great. Yeah. Yeah, in a world of celebrity culture, I want to shout out to Kathy Bates because obviously it's exposing her own vulnerability and her own medical history to a world that can be pretty nasty around really any place of vulnerability.
Yeah, absolutely.
Yeah.
I think
Yeah.
she's been really amazing,
Yeah.
and doing it consistently probably for the last 10 years, I would guess, right?
Yeah.
That she's really been on the front. She's been on the board of things and just doing, I think, whatever they ask her to do. And she is out there.
Yeah.
It makes a difference.
It's great. So this phenomenon of lipedema is different. Can you tell us what that is?
Yeah. So lipedema often gets confused with lymphedema. And that's probably where most of my relationship with that comes from, because it's confusing for pretty much everybody. And so if the referral comes with lipedema, you go, okay. Or I'm very surprised. That happens 3 or 4 times in my career where it's actually the diagnosis is lipedema. But what it is that it's a painful fat condition. And so what happens, so this is it's incredibly rare in men. I think it can happen, but it's incredibly rare. So this is a woman's disease, right? And it's a painful fat condition. And what we see is the laying down of a really, we say, bilateral, so both sides, a symmetrical fatty distribution that kind of starts at the top of the pelvis, and it involves the buttocks, the hips, the thighs, the lower legs, and it stops at the ankles, right? And so what happens is typically these patients are presenting, usually they're presenting to me, the lymphedema therapist, with a lymphedema script, and in later stages of lipedema, they develop something called lipolymphedema. So lymphedema accompanies later stages, right? So we get swelling in addition to the painful fat. One of the major differences is that it's painful. So these are patients that will say, I bruise really, really easily. This is a strange story that I've heard probably 20 times, is that when my cat walks across my legs, I have bruises afterwards. It's
wow.
one of those weird history-taking stories you hear and say, isn't that interesting? How many times I've heard that?
Yeah.
So very light pressure can bruise. So they have really fragility in some of their capillaries, so the blood vessels that just make them bleed more easily underneath the skin. There's oftentimes some joint hypermobility. So often these are people who have knee pain or have had knee surgeries because again, also the fat deposition. So when they lay down fat, they have a lot of fat kind of on the inside of their knees and in their thighs, and that will change their mechanics of walking, which also puts a lot of strain on their joints.
Keri, what does it look like? So, we can't show pictures on this show. So if you could describe what does it look like?
I think once people see pictures of it, when I show women pictures of, I think this is probably what you have, and they go, that's my body, right? You go, aha. So one, just Google lipedema and look at pictures would be your first guess if you're looking at it. But what we really see is it's not just obesity, right? What we're looking at is lay down of fat that's out of proportion. So we've all seen them when you're in the grocery store. You've seen people like this. They have a very small and slender upper body that does not look like it matches their lower body. Their lower body is much larger. They have really wide hips and thighs, right? And it's just completely out of proportion.
Yeah. And there's bear with me, there's a contour. It's not like a balloon that's blown up. It's a balloon that's got all these different sections and so ups and downs.
It's
which
lumpy and bumpy.
Lumpy and bumpy, that's right.
And there's also what we call like nodular fat. So they will often have little marbles of feelings of fat within their tissue, which are usually quite painful for the patient as well.
Do we know why this happens?
No.
Okay, so we don't know if there's genetics. Really we don't know if there's genetics.
There probably is, right? Because it's been another. You want to talk about things that haven't been researched? Well, this is trailing lymphedema by a lot. It's like originally diagnosed like a rare adipose disorder, but you go, I don't know. You can go to the grocery store and see these patients quite frequently.
Yeah.
So I don't think it's that rare. I think it's just been considered some version of like hereditary obesity. Like the women in my family have big thighs or we have heavy legs, right? These are typically like, oh, this is what we look like, right? This is one of those features that hereditarily we look at. So likely there's probably some combination.
That makes sense.
It's also very much exacerbated around hormonal changes, right? So it's puberty where you usually start to see those onsets of that tissue. Worse around pregnancies, worse around menopause. So there's also probably, a big driver of what's causing that inflammatory cycle that lays down the fat. The fat is different too. It will not be lost with weight loss. That is the other
That's the question I have for you, because will weight loss affect lymphedema or lipedema?
So weight loss is always our friend, right? So we certainly know, like, one, people are more at risk of getting lymphedema if their BMI is over 30, right? So the development is at risk. And we also know that it's exacerbated by being of a larger size, right? And so, but what we will see when we really talk about, so lymphedema often responds pretty positively to weight loss, right? It will create significantly less demand on the system. There's less tissue that needs to be drained. The inadequate system has a better chance of kind of catching up when we're at normal weight. Will it cure it? Most of the time, not. But we will also see just the other side of that is with severe morbid obesity, people can develop lymphedema for that reason alone, right? So certainly there is a tie with weight with that. When we look at the lipedema side, it's a little bit different. So often those patients have gone on, starvation diets many times throughout their life, and they don't lose the weight from their legs, right? And or they've even gone as far as having, because it can be tied. People can have obesity and lipedema at the same time. We can also see lipedema without the obesity piece. And sadly, I'd say that the prototypical patient I see is a woman in her, late 40s, early 50s who has been basically labeled as this sort of fat, whiny woman.
Yes.
And, maybe given a fibromyalgia diagnosis or something like that because their tissue hurts, and that's probably the only thing that someone's willing to come up with. And they feel ashamed, right? Like, unfortunately, that's the piece. And I think, the amount of times people have cried in the office over realizing like it's not your fault that you're not losing this. Like I've even had patients who have had gastric bypass done and then been told you're a slow loser, right? Or you're right, you're just not losing weight as rapidly because you're losing it from the other parts of your body, but this lipedema fat is really resistant to weight loss. Really the only way you can lose that fat is through liposuction procedures, right? And that is kind of an emerging area that we're really seeing, again, a lot of advocacy and push to try and get insurance coverage for it because it's not cosmetic liposuction, right? This is medically, necessary surgery for people who have it's incredibly difficult for them to function. It's painful to sit. It's painful to stand. Like I said, it'll create issues in terms of joint mobility, so once that fat has been laid down, really liposuction becomes the option. Stopping it from progressing, right? There's a lot of other things that we can do along the lines to stop that from happening. But getting rid of that fat once it's there is really, really difficult. And like I said, really going to be driven like through surgical procedures. These patients also benefit from the use of compression, right? So they're much like the lymphedema patients we talked about. We put them in compression pantyhose, things like that to support the tissue. It helps to get, again, if there's a lymphatic component, fluid that's sitting in that tissue that's kind of stuck there, it helps us to mobilize that and get that out. They also really benefit from manual lymph drainage, which is the massage that we do to mobilize fluid. And in many ways, because it's a very light technique, it really helps with the sensitivity and the hypersensitivity that patients have in that skin and that tissue. So hopefully, again, they're able to tolerate touch a little bit more. They're not having as much pain. So it can really help to downregulate, again, it's that question of, are we really moving fluid in these patients? Or are you actually just kind of working on their nervous system and getting that sort of resorted out so that it's processing and managing touch and pressure in a more normal way. It's also important those patients exercise, right? And usually what we want that exercise with their compression because it's going to help massage and move all of that tissue and that connective tissue basically with that movement. And again, help mobilize fluid, help massage the tissue and create, as normalized an environment as you can.
Great. Well, that's a perfect segue to talking about exercise, but I want to point out to our listeners, please, if you're looking at your body and realizing that it doesn't perhaps look like others from the perspective of swelling and pain and fat deposition and the way your particularly lower extremities look, please address it with your physician. Don't let them say it's just you need to lose weight because it may not be. Seek out help from a physical therapist. There probably is a lot online about these issues.
There are great resources. That's what I was just going to say. I think what I have found is patients are so much better educated these days because they've gone looking. There's numerous Facebook groups. There are, numerous groups out there that just offer support where people have said, this is what I've tried. These are the good doctors. These who you can, and really giving them a community to really help them manage this disease process that no one's paying attention to.
Yeah, great. Well, thank you for sharing your expertise. I so appreciate it. So we're going to pivot to exercise, which, is just a huge topic. And I would suspect it's something that's spoken about in almost every clinician's office. It's a lifestyle recommendation that is pretty just standard of care these days. But the way that clinicians particularly talk about exercise is probably as varied as the clinicians themselves. So there's very little consistency in the messaging that's going around about this kind of wellness technique. Also, what happens in my office is women will say, listen, I'm working 2 jobs, I have kids, my life is busy, and I never stop moving. So I want to first just start with how is movement, which so many people have plenty of movement, how is movement different from fitness or from exercise? How might you structure the way we think about this?
Yeah, so what I always default back to is to really look at, this is one of the things the government has actually done a really great job on, is really looking at the physical activity guidelines, right? And physical activity is, I think, a better way to talk about it rather than looking at it as fitness or movement, right? And so those are, and I'm sure you're familiar with them, 150 minutes of moderate intensity physical activity a week. So that works out to be about 5 sessions of 30 minutes each. Right. What that means is that's sort of a moderate intensity. So that's going to be something that's aerobic in nature. It can be multimodal. We can talk about the different versions of how you exercise and what that looks like and how we have to take care of all of our systems at the same time. But it basically is that plus 2 strengthening sessions a week, right? So muscle strengthening that focuses on the major muscle groups of the body. And the beauty of that is that that's pretty easy to remember, right? And guess what? It's the same if you're a young person, if you're an older adult, if you're someone who has chronic disease processes, it's all the same.
Well, you just answered a whole bunch of questions all in one fell swoop. I love it. So I'm going to be simplistic. So, Keri, I carry my own groceries. I carry my own laundry. I will sometimes pick up the 50-pound bag of dog food for my animal. These are the things that many, many people do throughout their day. Is this okay for strength training? Would you say, hey, Amy, you're doing enough?
Well, it depends.
Darn.
Depends. Probably not, but maybe, right? It depends on how intense that is. So I think, part of it is to start to think about what does that moderate intensity mean and how do you quantify that, right? One of the other pieces that it needs to be in at least like 15-minute increments, right?
15 or 50?
15.
Okay.
Right. So if you're doing it for like less than 15, you're not really getting the benefit that we're looking for in terms of that aerobic cardiovascular benefit. So if we look at a 0 to 10 scale, 0 is sitting here doing kind of nothing. 10 is the most, vigorously intense activity that you can think of. Moderate intensity is going to be like a 5 or a 6 on that scale, right? So it's kind of hard.
Yeah.
Right. So that is one of the ways, go, well, what does that mean? So that means my talk test, I can still talk while I'm, we're power walking and we can still have a conversation and that's working out okay. But I probably can't sing a song, right?
Okay.
So I'm working that hard that if I asked you to break into song, you're not going to be able to carry that tune. When we look at vigorous activity, right, that's going to be up the scale at more like a 7 or an 8, right? So actually, I go back and revise my guidelines. The guidelines also say 75 minutes of vigorous activity could be replacing that 150, but that's kind of higher up on the scale,
right?
That you're doing more intense activity. So the 7 or 8 is going to be, it's really hard to talk now, right? It's hard to talk while I'm doing this exercise. So that's a general way to just think about where we are. The nice thing is that if you're a super fit elite person, what you need to do to get to vigorous activity is very different from a sedentary, older adult who's maybe coming off of a disease process that has really made them unable to move as much. So that scale, again, can kind of apply to everybody in terms of their intensity, because it's sort of like the pain scale. Well, what does that mean? 0 to 10. It's different for everybody, and that's okay. We want it to be because your fitness level and your baseline fitness levels are going to be different.
I see a lot of people with watches and Fitbits and different technology that's come out over the last, 5 years. Do you think that that's helpful to people? Have you seen it impact the way people are moving?
I think it certainly can be. I think, come out and say 10,000 steps is sort of a nice round number, right? So that has created this idea of, okay, that's the goal. Not really science around that necessarily. Right. It's just a round number. However, we do know that, right, there's like a relationship between the more I move and, the less I move, more mortality, right? Like we know that there is like a pretty direct relationship to that. And I think the challenge becomes, so certainly as a physical therapist, in the population that I'm working with are people with disease processes, injuries, illness that have caused them to have a substantial reduction in their physical activity level. And then the question is always about how do I get back to a level maybe that I was at before? And the challenge is that, when my Fitbit tells me, my goal is 12,000 steps today, but I've, had a broken leg for the last 2 months and now I'm starting to move again, right? We're not going to get back to that immediately. So I think, one, it can create unrealistic expectations for people in terms of how fast they're going to get back into that. But I also think it is great because it gives you some basic data on how much am I actually moving. Because I know that, particularly if you've had patients who have maybe, had like a stroke or something along those lines, their mobility is way down, but the intensity that it takes to walk 20 feet is very vigorous, right? So you have to start thinking about it in that way. what I have often encouraged patients to do is, again, if you have a device that works great and an app, you can look at what your daily step count is. But, the goal is to start to say, where are you right now? Right? What's your baseline? So same thing. I talk about this a lot with patients coming out of like chemotherapy and things like that, because those are a lot of patients who are previously fit and now are trying to figure out just how to navigate a return to normal.
Right.
And that may be a bit of a path to get to that. So I think part of it is to always say, don't do anything different and see what you're doing for the last, 3 days, right? Just see what you're averaging at. And sometimes it's very surprising where you go, oh, I'm only getting 2,000-3,000 steps a day. So if I'm making my goal 10,000 and I'm going to be depressed if I don't get there, you're setting yourself up for failure. So the rule I typically talk about is like the 10% a week rule, right? It's, go slow, right? So if I'm walking 1,000 steps a week, then I'm going to add 10%, 1,000 steps a day, I'm going to add 10% next week, right? So then, okay, I'm at 1,100. And so that's going to grow exponentially over time, but it also gives me sort of more meaningful, achievable goals that are going to help me sustain that process and that progress over a longer period of time. Because I think, unfortunately, it's just trying to, say, well, this is what I did before. You got to find a pathway to get back to that.
Right. Yeah, I see this wearable technology as it can have, has two sides, as you've pointed out. It can be really motivational. It can be objective data, particularly for the person who says, I'm not sure if I'm exercising enough. I have no insight into it. Mm-hmm. But it can also be shaming and it can be discouraging. So, I would say to our audience, figure out what role it has for you. And just because your mother, brother, and sister have it, does it mean you need it? No. It just means you need to ask yourself, how am I going to use this information? So a question that I have to ask on a personal level and just a professional one is, there's no question now that I'm 63 years of age, is that if I don't exercise for, let's just say 10 days, life gets in the way, or I have a terrible cold or whatever it is, and I go back to my exercise routine, I'm like, holy shit, this is harder.
I find that at 46.
Yeah.
Right. And you go, I haven't run that much this week. Oh, that was really hard.
Is it true that as we get older, kind of getting back to it, even if we're healthy, if you will, is harder?
Yeah, I don't know that I have the absolute science to back that up, but I'm with you. I mean, I think it's like one of those, the effort that it takes to sort of get yourself into quote unquote shape is certainly more as we continue to age. And that is without, any disease processes on top of it, right? And I think like that is that piece. It doesn't necessarily mean, though, that just because I'm aging, I can't be fit and I can't do all this thing. And I think like that's the challenge that people get, where older adults get significantly less physical activity than they really should be getting, right? And the idea is really that is going to be associated with a lot of really positive things if they can do more, right? You do more in your life. You have a higher quality of life. You feel more capable. Cognitive improvements, right? It's like an unlimited list, which is why every doctor you see is talking about it, because it is almost like the panacea of physical activity does kind of cure everything. It is a bit of the fountain of youth. So I think there are certainly age-related changes that we see as we go along, and different precautions, perhaps, if there is a disease process, or if you're somebody who's at risk for something like osteoporosis or things along those lines that we have to take into account. But everybody as a human being needs to move.
Yeah. Yeah. I mean, when you look at primate communities, the older apes don't stop moving. They're doing everything they used to do. They're just maybe moving a little slower.
Yeah. I mean, it really is kind of a use it or lose it world, right? And if you're not, kind of challenging the system in all those ways, right? So I think like the other piece as we age that we have to start thinking about is like balance.
Yeah.
Right? I think that's the other, we don't think of that necessarily as exercise in our youth. Maybe if you're doing fancy yoga poses or, but as we continue to age, we really have to make sure we're incorporating things that challenge that system as well into the things that we're doing.
Can you give a recommendation to the audience of how to address balance in a simple way?
Yeah. I mean, there's actually studies that show standing on one leg, 30 seconds, right? Kind of stand at your kitchen sink, fingers hovering over the counter, catch yourself when you need to, let go as quick as you can as you recover that balance, and do that for like 30 seconds to a minute a day. over time, what we actually see, I can't remember how long the study was, but, do that for 3 months perhaps, and their balances in the group that was doing that was substantially better than before they did it. So it doesn't necessarily take a ton of input.
Right.
But we need to challenge the system. The problem is that as people, again, either have disease processes, because, again, it's not necessarily a normal course of aging. I think that's the other big drum that we say, right? It's like you can see the 100-year-olds that are out there doing amazing things, right? It's not necessarily just because we're aging. Aging's playing some role, but it's really inactivity, immobility, and then, again, the influence of the different diseases. But the idea is I'm at risk of falling, so I don't do as much stuff. I don't take as much risk. And then what we call that is like the spiral of disability, right? So I risk less. I don't challenge my system as much. I mean, you think about it from being a small child and playing on the monkey bars and all the crazy things that you would do. And you look at that now and say, I'm going to do that. Right? We just stop.
Yeah.
And you go, there's no really good reason. There are certainly, acrobats at our age that are doing amazing work, right? But so I think it kind of goes to that effect to say, okay, I have to make sure I'm doing things that challenge myself. And there are, numbers of like good senior exercise classes, in the community office for aging puts on a number of things that help work on these type of things. But again, things like standing on one leg, doing the DWI test of walking heel toe, right? Those kinds of things. Closing your eyes and standing, right? Marching in place with your eyes closed, trying to stand on one leg with your eyes closed. Taking vision away really challenges the system in a way, that, we don't realize, it's a lot harder to walk to the bathroom in the dark than it is when I have light, right? When we lose the key inputs that we're getting from the visual system.
Right.
So all these things, it doesn't have to be hard. It just has to be somewhat consistent, I think, is the big challenge with the system.
Great. Those are wonderful examples. I actually stand on one foot when I'm brushing my teeth.
Yeah.
I mean, it's just,
It's multitask. That's actually harder than just standing on leg. We talk about that.
I haven't tried doing it, close my eyes.
We talk about that as dual task balance or doing addition, right? Actually having to do something cognitive at the same time that you're doing balance is actually harder, right? It's like, patting your head, rubbing your stomach. It's that kind of level of dual tasking actually is harder. So, carrying this glass of water while I walk, I have to focus on not spilling it while I'm trying to do all these things and maintain my balance.
Interesting. So, it's really speaking to neuroplasticity.
Completely.
Yeah. So what happened during the pandemic, what I thought was very interesting, it was kind of this paradox. There were people who were exercising more at home because they were getting virtual classes. Yeah. Peloton sales just blew out the roof. And at the same time, people were no longer walking to work. They were no longer walking to the bus station. They were no longer using, they were more sedentary because home office was there. So I guess what I'd like to ask about, because people ask me all the time, is like, okay, Dr. Novatt, what's the best machine I could get if I'm going to create a gym at home? What's going to take care of it all? And I kind of shrug my shoulders and usually say, I don't know that there's any machine that does it all, but what would you say to that?
My first answer is always the one that you're going to actually use, right?
Indeed,
so I think like that is the most important thing. Like you have to find some modality of exercise that you enjoy,
right?
Because if it's drudgery, you're not going to stay with it.
That's right.
You're just totally not going to stay with it.
The cost of it only is a seductive initiative or imperative for so long.
It's like the bright shiny new car. It's got new car smell for a bit, and then it's holding your laundry, right? It's collecting dust and having hangers all over it. Yeah. So I think it's really about it's about choice, and I think it depends on your personality and who you are, like what things you like, right? I like to run. I have a treadmill because I don't love running in the pouring rain or the freezing cold. But I'd so much rather be outside.
Yeah.
Right? I was out running this morning. It's a beautiful day. It's beautiful, leaves blowing in the wind. It's just wonderful. Like you can just, absorb yourself in nature, let yourself kind of go and get all the benefits that you get with that. So whether it's going outside and taking a walk because you want to see nature's beauty, whether it's I like to do things by myself, whether, I'm more motivated to work if I have a group to be in. I think those are important things, too, to just look at, your accountability buddies or the fact that, hey, I just really like to get together with my friends and then we go exercise together. So it's not work necessarily in the way. So I think you've got to figure out your own personal motivations and figure out what the thing is that motivates you and is going to keep you going. And for some people, it's like, well, I don't have transportation. I can't get to a gym. Okay, so then find, you're a great candidate to find something that you're going to do at home.
Right.
And whether that's
Right.
YouTube videos, whether that's, again, a piece of equipment, kind of whatever makes people happy, I think, and consistent is the best thing that they can do.
Yeah, and you've pointed out, so many women say to me, oh, I'm not exercising because I hate going to the gym. It's like, oh, there's no excuse anymore.
Yeah.
There's just so many ways in which to move the body, get physical activity. I mean, again, if you find a stairwell, up and down the stairs a few times, and that gets most of our heart rates going, right?
Absolutely.
It's such an interesting, it's one of those things where, like, we know for sure there's so much science that demonstrates the benefits of exercise, and yet for so many people it's a major obstacle. And I think it's sociocultural, I think it's the realities of economics, I think it's a lot of different things.
Absolutely. I agree. I think, it's not an easy, right? It's the easy answer, but it's not easy to actually go and achieve that, right? And I think, and it depends, right? It's people's demands on their time. I think that's the other piece to really look for and say, okay, when is that time? Like, I know I need to exercise in the morning because I'm going to get stuck at work and I'm not going to do it after. I take that gym bag with me and put it in the car, and I never get those clothes
The car
on.
just drives you right home to your pajamas.
And it just doesn't happen, right?
That's
and
right.
so like
That's
I think you have to figure out like what are your family obligations? What are your work obligations? When are the times that you can get this in? Okay, maybe it's 9 o'clock after the kids go to bed, right? So maybe I have to exercise at home. I think you just have to try and figure out, okay, how do I do this? How do I stay consistent? How do I make myself a reasonable goal, right? So I think we go back to those exercise guidelines for physical activity, right? You're saying, the 100, in 50 minutes is going to be 5 days a week, right? So I think like that's a reasonable thing. It could be longer on other days, but it also means it's not every day I do this, right? There has to be also that idea of like, if I fail today, it's okay. I'm going to try again tomorrow.
Yeah.
Right? Because I think that is what I see a lot of times in the people I work with is that the minute I'm gung-ho and then the minute I don't do it, I'm just done. I'm not getting back to that because I feel like I failed. There's a whole, self-shaming cycle that goes on with that. And I think it's just like, okay, this is what we did today. Try again tomorrow. Do a little bit, see if you can get those minutes in.
Yeah. And isn't there some science that demonstrates the benefits to exercise holiday or what we call, I think it's called fitness recovery, that you can take a day and not exercise. That's not going to, throw you back 3 years. It's in fact,
absolutely.
Yeah.
And the other thing is that there's also really good science that says something is better than nothing.
Well
right?
put.
Like,
Yep.
so being partially compliant with those guidelines, right? Getting 75 minutes of physical activity a week is still going to be better than 0 under any circumstances. So I think like just set a goal that is achievable now. And then, once you're getting closer to achieving that, then revise your goals. I think that is the single most important thing that we need to do, and just be gentle with ourselves.
Yeah.
I think that is the other, it's so much, exercise is so much caught up into, I'm a failure. I didn't do this right. I should have been doing this all along. I don't know why, So I think part of it is, today's the new day. We start from today and you just keep looking forward.
Yeah. I wonder whether exercise or diet is the most commonly stated New Year's resolution. I imagine it's up there.
They're probably tied.
Yeah.
And in the attempt to do everything at once, they're probably the dual factor.
That's
I'm going to eat completely differently and I'm going to exercise every day.
Right.
And then by January 15th, none of that's happening.
Yeah. So I have one last question as we move towards the end is just this concept of doing things in reverse. So I often read about like someone who walks or runs, every once in a while turn around and do it backwards, or when you're pedaling to do it in the reverse. As a physical therapist, is that an important thing or is it just a silly notion?
Well, I mean, I think, you're working slightly different muscle groups, right? You're challenging your balance system, right? Walking backwards is one of our other favorite type of simple techniques that we do. If you have bad balance at home, that's not necessarily the one I'd want you to do unsupported. Falling backwards, is not what we want you to do in your kitchen. But but certainly in a safe environment, that is something that we do a lot with patients. It takes your vision away again as to what you're doing, right?
Okay.
It makes you process in different ways. It's moving backwards is less of a pattern, right? So like those motor plans and patterns that we have when we move forward are pretty hardwired, right? It's just, you don't think, you get up and you walk, right? When you first learned to walk, you fell down a lot as a baby, but you don't think about walking an awful lot anymore. So it's just sort of an automated plan that we kind of go through as we're moving in that way. When I turn around and go backwards, I don't really have that hardwired in the same way. So I'm definitely getting different, neurophysiologic benefits of doing that. On some level, it's probably a little faddish at the same time too, right?
Yeah.
Just like the weird person who's running the marathon backwards for, the Guinness Book of World Records. And more power to them. I couldn't do it, right?
Indeed.
Yeah.
Great. Is there anything else you think the audience should hear about exercise in detail or in general that you'd want to have them know?
Yeah, I think part of it is always think about, you got to take care of your whole body, right? So we think, aerobic cardiovascular stuff, again, that's what we're talking about in terms of that moderate intensity activity or the vigorous activity. You got to think about strength and muscle building, right? So that you're actually using your muscles. And that can be things like squats. That can be things like, push-ups. Those could be light weights and resistance in that way. But you got to be challenging those muscle groups. You also have to think sort of about, again, we talked about balance, but also think about your bones, right? They also need that weight-bearing activity that really is going to help, keep them healthy over time. So you want to make sure that, you're doing something that's getting you that weight-bearing both through the upper extremities and the lower extremities. That really helps reduce the risk of fractures and issues in terms of developing osteoporosis along the line. So I think it's just important to, and then don't forget flexibility. I'm like, there's one more in there. I need it on the list. Flexibility, right? That's also important, that we're trying to maintain, length in our tissues, suppleness, the ability to bend down and tie that shoe is, again, important, just not because, oh, well, this is what I should do. But as we age and we see what happens in those processes with diseases is, I want to be able to put my own socks on.
Right.
I want to put my own shoes on. I want to live independently and have a higher quality of life because I have this baseline level of mobility and function. And I think that's the biggest thing, is to really think, okay, things don't get easier as we age. They certainly get harder. And so the best time to start is now, right? That's probably the biggest advice I would say.
Yeah. Great. All righty. Well, Keri, I can't thank you enough for your expertise is just abundant. And I love the enthusiasm that you bring to talking about it. So are you doing something this summer for your own pleasure?
For my own pleasure. Well, I have been training for half marathons. So
Woohoo!
I've done 2 already this year. So I have another one coming up in August.
Wow.
So that should be fun. Yeah, that's, running is my jam, right?
Yeah.
It's like I like to just go out, run by myself, be alone, no music most of the time, just, with my own thoughts and quiet, you know, and that just really helps me stay together.
Yeah, I'm so glad that you have carved that out for yourself and that your job allows you to do it. I know how hard you work.
Yeah, no, I think what I have found is it's not necessarily the job allows me to do it, but that I make myself do it because I'm better at my job and everything else when I do.
Touche. Again, thank you.
Thank you.
I also want to thank my co-producers, Matt Rosenberg and Jan Hammoud, and the Epicurean, who very kindly host Radio Free Rhinecliff. Until our next episode, please stay well. Listen to your instincts and intuitions. They are the greatest of teachers not to be ignored.